All right, if everyone could take their seats, we're going to get started with the afternoon portion of the course. All right, without further ado, Dr. Krishnan.
You guys had a wonderful opportunity to escape and you blew it. Came right back. All right, we'll get started. Is there, Joe, are there any particular questions I can address from the morning session that anyone had a burning desire to ask?
Deepak, give us 1 second. We're turning the volume down. It's too loud in here.
Well,
go ahead and talk for a second.
Are there any questions from the morning that I could perhaps address?
I think we're good.
Okay. All right, we'll start with your postprandial torture. All right. How many people in the audience treat children under the age of 13 in the office? How many people in the audience treat children under the age of 7 in the audience? How many under the age of 5? All right, you guys are all good. Nothing to worry there. But it's important to talk about pediatric sedations because I don't know if you've been following the news lately, because there was a death in a pediatric dental office just day before yesterday in Vancouver. And that was an unfortunate incident, and these things tend to happen quite often. And I'm not quite sure what happened with that particular incident, but I serve on the Committee on Anesthesia with AMIS, and we get an opportunity often to review these cases and to figure out what we learned from these and what mistakes were common in those. And it seems that most of the time it's not an intention to do harm, but it so happens that somehow things went wrong and we were not prepared to catch that when it did go wrong. So what we're going to talk about today is about pediatric anesthesia in the oral maxillofacial surgery office, what, when, where, how, why, and how things go wrong. Of all the patients that receive deep sedation and anesthesia, especially outside of the operating room setting, the pediatric population is the subgroup that is at the highest risk level and with the lowest tolerance for error. And so much so that the opposite side of that is where deep sedation or general anesthesia is required more often for children to achieve acceptable conditions to undergo a procedure. There is no other population that's much more anxious and probably vulnerable to all of the dangers of what we do. So who is that pediatric patient and what makes them different from the adult patient? Well, they're very different. They're anatomically different, physiologically different, and certainly different behaviorally. And like I said earlier, I just don't understand what the big deal is. Kids are not just small adults, you know. There is a big difference. Kids are not just small adults, and they are quite different in every aspect of their management. And just to go over some things here, just for review, a neonate is this little guy here that's less than 30 days old, and an infant is probably this guy here, less than a year old, and anyone from 1 year to puberty is considered a child. And oftentimes that is a distinction that's difficult to make as well. And the anatomy and physiology is what we'll focus on with, as far as children go, the pulmonary, cardiovascular, metabolism, renal, and GI. Like I said earlier, children are quite like Martians, big heads, protuberant bellies, thin neck, and everything about them is different. We used to assume that children have a short trachea and a narrow cricoid which is funnel shaped. And this was true until about a month ago. A new paper came out and looked at a lot of children's CT scans, and they found that actually children don't really have a funnel-shaped airway. It's actually a cylindrical airway, much smaller, and of course the rest of it holds true. They do have a proportionately larger head and tongue disproportionate to the size of their neck. Their nares are very small. They have a much more anterior encephalad larynx at a level of C4 versus C6 in adults. To have a long epiglottis and a really short neck and a short trachea. But the shape of the trachea that was previously considered funnel-shaped has been debated and has probably been found to not be funnel-shaped. Because of their physiology, children are at a higher risk for respiratory depression and life-threatening hypoxia. The pulmonary system in children is significantly different because they have an oxygen consumption that's about double of what it is for an average adult. Adults consume about 3 to 4 ml per kilogram per minute of oxygen, whereas children need just about 6 to 8 of that. The lungs, if you notice, is rather different in both shape as well as shape of the chest wall as well as the lung compliance. They're small and less alveoli in number. Their increased chest wall compliance is due to their horizontal and cartilaginous ribs as opposed to an adult. They're very prone to chest wall collapse during inspiration and lung residual volumes, low lung residual volumes when they expire. And they have a decreased FRC overall when compared to an adult, kind of like having asthma, except now a child with asthma makes that even harder. They have less efficient ventilation. Obligate nasal breathers till about 5 to 6 months of age, weak intercostal muscles, quite weak diaphragms, horizontal and more pliable ribs, protuberant abdomen, less developed alveoli. And despite all of this, children somehow keep up. They don't go blue just like an adult does in case of oxygen deprivation. Not quite sure why that is. So if somebody has increased consumption, increased airway resistance, and a decreased reserve, how did they survive those odds? Well, if you can't increase the volume, you increase the rate. And that's why the minute ventilation in a child is much more than it is in an adult. The respiratory frequency in an adult is just a child is just about the double as that of an adult. So you make up for a lower tidal volume, you make up for a lower FRC and an increased consumption of oxygen by increasing alveolar ventilation and also increasing respiratory frequency and rate. If you look at comparison of pulmonary variables in children, neonates, infants, adults, all of these you can see is so different as opposed to a 70 kilo adult to a 3 kilo neonate. You can notice that across the board everything is quite the contrary. So cardiovascularly, neonates and infants have a relatively non-compliant and fixed left ventricle, which basically means that their stroke volume is reliant on that movement of that ventricle and is hence decreased. Cardiac output is largely dependent on heart rate, which is why children have a rapid heart rate. Both systolic and diastolic pressures increase with age. And so all of this contributes to the fact that children have a sort of, on one hand, a much more mature cardiovascular system, but on the other hand, quite an immature one. But somehow the immature cardiovascular anatomy is compromised by a mature cardiovascular physiology. If you think about the rest of the regulations in the cardiovascular system, their sympathetic nervous system, as well as their baro and chemoreceptors, are actually quite immature. They have a lower catecholamine stores, a blunted response to any kind of catecholamines or steroids you give them externally. So neonates and infants with intravascular depletion may be actually hypotensive, but they don't necessarily show the tachycardia. So even if that gas pedal hits the floor, that machine's not really going to rev up quite a bit. So most of their cardiovascular content and oxygen delivery, oxygen content and delivery is dependent on the heart rate and not necessarily the stroke volume. And for some reason, at that point, nothing becomes dependent on any of the cardiovascular anatomy, and most of the cardiovascular compromises in a child becomes pulmonary driven, which means that if you cause hypoxia in a child, That can lead to bradycardia and quickly to hypotension. And the only way the child's heart knows to deal with that is by causing asystole, and that leads to death. So metabolism in a child, because they have this large surface area per kilogram, they have a greater surface area that correlates to increased oxygen consumption, carbon dioxide production, cardiac output, and alveolar ventilation. They also have the large surface area, which means they have this heat loss to the environment. Their skin is thinner and smoother, and actually the skin itself actually has low fat content. There is a higher surface area to weight ratio, which if you put a child in an OR, now all of a sudden it's compounded by the fact that the operating room environment is cold, wounds are exposed, you're giving them cold IV, giving them dry anesthetic gases. All of this can directly affect anesthetic, the temperature regulation of the patient. So if you do drop the temperature in somebody, the hypothermia as it relates to anesthesia leads to a delayed awakening. It also irritates the heart a little bit more and can cause respiratory depression in order to calm the body down quite a bit. Increased pulmonary vascular resistance occurs, and everything that you throw at them, including the medications, the gases, all have altered drug responses. So how do children actually cause some of the heat production? The major mechanism of heat production in neonates is called non-shivering thermogenesis. And what they do is they have the baby fat, the brown fat, and they metabolize that quickly. The problem with that fact is when you add volatile anesthetics to that equation, that non-shivering thermogenesis is actually reduced, and so children remain cold, and hence all the negative effects of hypothermia. A normal kidney in a child doesn't start functioning until about 6 months of age, sometimes even later. So this is why we have to be meticulous about fluid administration, especially in the office setting with a child who's been NPO for a while. The younger the child, the harder that balance. And there's a higher incidence of reflux, as you know, they have to throw up every time they eat. So if you can remember any part of that anatomy and physiology that I just talked about, understand this. Take home the fact that airways in children is more susceptible to obstruction. Obstruction causes hypoxia quicker in children. That hypoxia is the trigger for a cardiovascular event. Typically, that hypoxia leads to bradycardia. Increased parasympathetic stimulation occurs in children, which can be directly influenced by drugs and indirectly influenced by respiratory obstruction. Parasympathetic stimulation also leads to bradycardia. Their decreased cardiovascular stability and their immature anatomy leads to bradycardia rather quickly. If you can't remember any of that, what I just said, remember that bradycardia in children is really, really bad. There are 4 P's of pediatric anesthesia, and those are preparation, preventing poor performance. And that starts from airway techniques and tools, having your emergency drugs and their doses drawn up in your head at least, and keeping the cool when things go wrong. That preoperative evaluation starts with obtaining age and weight. And that weight changes. You see a patient this week, they come back 3 weeks later for their procedure, they're heavier, or sometimes they're thinner. You need to make sure that you get a weight on the day of the procedure, quite important. Obtaining a health history is important too, because they could have new diagnoses of allergies and adverse reactions. They could have medication history, relevant diseases, physical abnormalities, and neurological impairment that may increase the potential for airway obstruction. Ask for history of snoring when you see a child in the office. Find out, especially if the child is on the heavier set side, about obstructive sleep apnea. More and more pediatricians are becoming aware of the fact that there is obstructive sleep apnea in children. And a lot of that is central sleep apnea, not necessarily related to the patient's body habitus or upper airway anatomy. The summary of the previous relevant hospitalization, including any previous history of sedation or general anesthesia, and any complications related to that, is quite important. It also gives you an insight into the patient's understanding of what is going on, and with a child that's quite important. Sometimes it's not necessarily their own experience, but a sibling's experience that may taint their understanding of what they're going to go through and may influence their response to what you're suggesting to them. Relevant family history, particularly that related to anesthesia, should be included. women tend to have an increased risk of postoperative nausea and vomiting. If your mother has postoperative nausea and vomiting and you show up for anesthesia and surgery, there's a very good chance that you may have an increased risk of postoperative nausea and vomiting. If there is a distant uncle who went in to have a colonoscopy and ended up dead because of malignant hyperthermia, you want to know that. You want to know that kind of history from the patient when you go in to talk to them about their health history. The review of systems has to be quite focused on abnormalities on cardiac, pulmonary, renal, and hepatic function. Simple question is there anything wrong with the child's heart, kidney, lungs, or liver? Is just enough to get the pertinent review of systems out of them. Get a set of vital signs and do an airway-focused physical exam. Notice that children not only have adenoids but also have large tonsils oftentimes. Any kind of abnormal anatomy such as mandibular hypoplasia or a tongue tie, for instance, these are the ankyloglossia, needs to be caught in the airway-focused physical exam. What about upper respiratory tract infections? There is an increased airway reactivity 2 to 8 weeks after any kind of upper respiratory tract infection. But, that's not quite the same as you or me getting an upper respiratory tract infection and having a non-intubated anesthetic. Children are different because children are at about 11-fold risk of upper respiratory complications if they've had an upper respiratory tract infection or endotracheal anesthetic at the same time. Laryngospasms and bronchospasms significantly increased 2 weeks after upper respiratory tract infections. There is a 10-fold risk of wheezing, a 5-fold risk of laryngospasm, and the recommendation currently is to wait 6 to 8 weeks after resolution of an upper respiratory tract infection. Now, oftentimes you get a child referred to your practice from your friendly neighborhood pediatric dentist or a dentist that says he has a severe toothache, I put him on antibiotics, can you see him sooner rather than later? Kid shows up, he's got a runny nose, he's got a cough that sounds terrible, and you're willing to pull the tooth under local anesthesia, except the poor little guy is so scared he's not going to sit still. What are you going to do with those kind of patients? Are you truly going to wait 6 to 8 weeks after resolution of his upper respiratory tract? So the question is, are we going to or should we anesthetize children with upper respiratory tract infection, which is, recent but mild to moderate? So the consensus is that children with mild URI may be safely anesthetized since the problems encountered are generally easily treated and without any kind of long-term sequelae. In fact, anesthesiologists looked at this and they said, wow, we could have ended up canceling about 2,000 procedures to prevent about 15 cases of laryngospasm that broke with a little bit of positive pressure. And so there is upper respiratory tract infections, and then there are real upper respiratory tract infections. The problem is interpreting that data. How do you classify your upper respiratory tract infection? What is the type and duration of the procedure you're going to do? Is the airway really going to be instrumented? What is the technique of anesthesia you're going to involve? And, there are some observational studies, and of course when things go wrong, things really go wrong, we can't really say there's evidence behind making a decision, but since things remain controversial, when in doubt, it's probably best to postpone the case and come back at a time when things are easy and peasy. What is the NPO requirement in children? So 2 hours for clear liquids, 4 hours for breast milk, 6 hours for ingestion of infant formula and non-human kind of milk, and 8 hours for a meal containing fatty foods or meat. I was in training in my fellowship in Canada. Canadians do their anesthesia and their technique is a little different. One of the things that they do is they actually have all their patients come out for their procedures, which is usually with anesthesia, IV sedation, similar to how we do it, but they do it differently because they ask their patients to come in having what they call tea and toast. So they would have a light meal before they actually had the procedure. And there's actually quite a bit of body of evidence suggesting that a light meal actually not only helps the patients, but also there is no significant increase in the risk associated with aspiration or the concerns for laryngospasm and such. In fact, the NPO requirements for children often suggest that you can offer clear liquids up to 2 hours before induction, which primarily reduces hunger and thus irritability. You sometimes have a crying child in your office because of anxiety. But you don't want a hungry, angry, hangry child in your office, which can make management quite difficult. It also keeps the hydration up, and so finding an IV for that child when you need to start an IV does come in handy. It decreases the hypoglycemia. But then, of course, you know what to call what is clear fluid and what really isn't. Think of all the times that we've asked patients to come NPO, but they come into the office eating a bag of Cheetos because their mother said Cheetos is not real food and they should have real dinner. And so Cheetos, if Cheetos doesn't count as NPO guideline, I don't know if maybe a sip or two of clear tea or Gatorade might be just fine, I suppose. So the practice guidelines for preoperative fasting and the use of pharmacological agents is usually found at this particular web page. This is the American Society of Anesthesiologists and their health quality web page that they typically put out this kind of data and documents on. So there are multiple other guidelines on that particular web page, which I felt was important to share. So when I go into a room and I need to set up a patient for a sedation, especially a pediatric patient, this is what I think of. Because I've got a little bit of a crooked mind, I always try to find something perverted to remember. And in this setup, it's SOAP me up. SOAP me standing for do I have a suction, do I have oxygen, airway, do I have pharmacy stuff, which is my drugs, my monitors all ready, and is my equipment all checked, including my crash cart and whatever I need. So multiple. Because pediatric anesthesia calls for the highest quality of care, they have looked at multiple studies that look at tiny checklists and little lists like such as this to make sure that we have a system in place either in our offices or in our practice whereby we can make sure that we improve the success and the quality of our patient care. This is a paper that was done a couple of years ago out of Cincinnati Children's Hospital where they looked at quality and safety in pediatric anesthesia and how checklists and initiatives improve the outcome. Pediatric hospitals take checklists to another level. They beat the death out of checklists, and they make a checklist for everything and anything possible. If there's a checklist to be made, a pediatric hospital will make it, and ours is no different. Sometimes it's painful to work under such circumstances, but there is a reason why they do those things, and it makes it important. Now, the monitoring requirements. So it's funny because this is the American Association of Pediatric Dentistry that modified the ADA guidelines, and this is what is currently adapted as the guideline for monitoring requirements in doing anesthetics for children. And this is what you will find in the parameters of care that AMIS puts out for oral maxillofacial surgeons as well. I think it's a decent list. You need to have an emergency kit or a defibrillator or a crash cart. You should have a precordial stent, and then of course all the necessary equipment that matches the size and shape and age of the patient, functional suction with backup suction, and positive pressure oxygen delivery system with backup oxygen delivery system. The PARCare document, which is getting released again this year, will tell you that we need a time-oriented anesthesia record, and just measuring out things that they gave was not important, but it needs to be documented when each drug was given, no different from what you're doing now. The same thing applies to all the necessary monitoring. How many people use inhalational anesthetics in your practice now? Sevoflurane. Okay, so one of the small changes you will notice in the new parameters of care is that the ASA guideline for utilizing temperature or monitoring temperature for patients who are undergoing sevoflurane or inhalational anesthetic with a fluoridated gas is changing a bit. They have suggested that if the procedure is greater than 30 minutes, then invasive temperature monitoring needs to be recorded. currently in our practices, there's nothing that we do in the office that lasts more than 30 minutes in a child. Typically, it's a simple procedure. It's a quick on and off. But you know, even in those cases, the recommendation is that you at least get a preoperative temperature reading in case there is you know, obvious malignant hyperthermia related issues. In that case, then it's important to get the patient's temperature monitored. And all of these monitoring will be at least at 5-minute intervals. Who should you have in your practice? Now, I tried to look up Pennsylvania's laws, and I couldn't quite find this. So this is kind of universal as to what kind of personnel needs to be in your office. How many people in the audience are PAL certified? Yeah, all of you are. So PAL certification, I think, is important, especially if you are defending yourself, managing a child in your practice without the presence of a dedicated anesthesiologist. I don't know if you've heard about Caleb's Law. Caleb's Law is a new law that is happening in the state of California. Caleb was a young child that went into a dentist's office and did not walk out, had a terrible accident, and the child ended up dying. His aunt, who's a Stanford surgeon, is now questioning our practice of anesthesia as a single practitioner who's providing both anesthesia as well as surgical services. And Caleb's Law is looking to figure out how we can get around getting somebody else who's dedicated to monitoring and providing the anesthesia for pediatric patients. Now, that has really not gone anywhere, and primarily because we are at the zenith of safety in our practice of anesthesia, and the techniques that we use has been proven over time. And oral maxillofacial surgeons are typically not the culprits. There are other professionals within the dental profession that sometimes don't have the same level of expertise with pediatric anesthesia as we do. But what happens when something happens in the dental office, it's the same brush that paints us all. And they'll say, you know, they don't care if you've had 6 to 16 years of anesthesia training or you're still a dentist at that point that ends up killing patients in your offices because you don't want to spend the money on bringing an anesthesiologist into your office. Bad dentist. So that is where things are going. But what do we do in order to protect ourselves? We make sure that we have at least 2 other personnel, and of those people, at least one person will be dedicated to only monitoring the patient's vital signs, and the other one will be assisting or holding the patient's airway up. And of course, everyone needs to be BLS certified in the room. If you are PALS and ACLS certified, PALS and ACLS have some significant differences these days, and I would suggest that you consider taking both if you haven't. 3 individuals, level 3 and above, is required in a lot of other states, and a recovery room and the monitoring in the recovery room is required. Now, I don't have a dedicated recovery room. I recover in my office in the same operatory, but that's okay as long as a nurse stays in the operatory and records everything until I deem the patient is ready for discharge, and my signature needs to go on that. So 75% of all patients, regardless of whether pediatric or adult, are anxious patients, and that's usually a problem because that leads to a more difficult induction, more difficult maintenance, increased autonomic tone, and 3 times likely to miss appointments if they're anxious about the upcoming procedure. That requires more chair time because now there's a lot of hand holding you have to do. And I don't know, I'm getting to that age where I don't really care about hand holding as much. I want to keep moving my day on, and sometimes what you perceive as, okay, let's get on with this, may be seen as a little bit of unpleasant and not necessarily sensitive. So I got into trouble last week because one of my questions I ask all my patients, regardless of whether they're an adult or child, when I see them in the pre-op area, whether I'm in the office or in the operatory, I ask them, so what do you have for breakfast? It's my trick question, and it's to see if I can catch an occasional teenager that'll tell me that they had a big bag, big pack of pancakes or something on their way in. But and typically get a chuckle, and I usually hear, oh, that is a trick question, and the usual stuff. Except my patient last week wrote a complaint to the hospital administrator that I was not sensitive enough to her fasting all morning, and that I asked her what she had had for breakfast. So I got a hurt feelings report written against me. Now, I'm sure I have several hurt feelings reports written against me, so I'm not going to change my way of asking. It's kind of hard to get through that. My point is that you don't necessarily have a lot of chair time left to do the little niceties, and sometimes an unpleasant experience is an enduring memory, whether it's an adult or a child. So maybe there's a way to reduce the anxiety, because there are clear benefits in reducing anxiety. It definitely gets them to cooperate more, easier induction maintenance, attenuated autonomic response, more rapid recovery discharge, good points on Yelp. All of those things help. The range of anxiety can vary, obviously, and the question though is, how are you going to sedate this patient? You got a kid that is clutching onto his father and crying out loud, and he ain't going to sit down in your chair for you to hold that mask on his face or give him an IM shot of whatever you want to give. Now, the techniques of trying to deal with this should really reduce the anxiety, establish some amount of cooperation, ensure their comfort, build a rapport with them, establish some amnesia and analgesia, and ensure hemodynamic stability while doing all of this. And the considerations for all of those techniques, whether it's anxiolysis or actual sedation, should depend on the age of the patient, the level of their anxiety, and their ability to cooperate. Certainly needs to be taking their medical history and their prior experience into consideration, and the duration of the intensity of what you're about to surgically insult them with. Then, of course, is your training and your personnel and your facility and the equipment that you have. You all know what moderate sedation is. You all know what deep sedation is. You all know what general anesthesia is. The fact is that these things don't exist in any kind of space, little silos. There's just a continuum of sedation. The continuum of sedation is where we go through. We start at one end of it, and as the patient stops responding, sometimes that means that the airway is not maintained. Sometimes it means they're going to come right back to where nothing's needed and they're wide awake and you need to go start from the beginning. Oftentimes you go through these phases of apnea and agitation. Somewhere in between all of that you end up doing a procedure somewhat moderately. But if you recorded yourself doing a sedation like that and going through it and play back, it's not necessarily very elegant. So oral sedation is where I'm getting to, because there is some advantages of providing oral sedation in children. The advantage, obviously, is that it's the least threatening way of giving somebody a medication, and it definitely gets to pre-medication prior to IV access. There's limited volume, highly unlikely to be aspirated, and it comes in all kinds of creative methods now. There are popsicles and syrups and needleless syringes and creative ingestives, and there are stickers you can put on and things like that. So the problem with oral sedation is you can never get the response right. For the one kid that you want them to sleep well, that will be the one that will stay up and play until you give them more. And when you give them more, they'll be like wide awake again, and then you give them more, and then you know that that variable response is so unpredictable when it comes to recovery. Sometimes they don't like what they're being given. They cough, they cry, and they can aspirate as well. So in my hands, the sedative techniques include the oral, intramuscular, intravenous, and inhalational. We'll talk about all three of these and talk about a couple of other ways of treating children as well. The enteral or the oral kind of pre-medication is easy, convenient. Like I said, multiple ingestives, creative ingestives, and least threatening. It requires minimal training. Any one of us can give somebody something to drink, and the drug reactions are usually less severe. That first pass mechanism takes care of most of the drugs, and then the reactions are usually nothing big to deal with. Usually there's no increase in your malpractice premiums if you are somebody who practices oral sedation. Primary objective is obviously to reduce the anxiety and get them in the chair. It permits at least local anesthesia in the mildly apprehensive patient. Sometimes turning on the nitrous oxide helps to help with that as well. The secondary objective is obviously the patient shows for appointment, and that is something that we have to do from the get-go. Allows acceptance of masks or IV. The problem is that, sometimes the patients are not necessarily cooperative. Sometimes the parents are not cooperative. It's an empiric dosage. There's no titration and erratic absorption. Extended time of action and that variable response and unpredictable recovery pattern inadvertent aspiration can sometimes occur. So if I had to make an ideal pre-medication, need to still rapidly absorb, rapidly come on board and have a high therapeutic index with a quick recovery so I can get them out of my office as soon as the procedure is done. What are the current drugs that are available? Benzos, histamine blockers, opioids, scopolamine. I don't use chloral hydrate. I prefer people don't use chloral hydrate. Barbiturates, alpha agonists such as clonidine. We talked about clonidine this morning. Dexmedetomidine or Presidex, which is the nicest new drug on the horizon, which is making its way into our practices quickly and has its definite pluses. Always I'm interested in alcohol, and I always look up, have anyone attempted giving patients alcohol for pre-medication, and guess what? Niels Johansen found that giving the alcohol of Johansen, he had less fainting during local anesthesia injections. And as recent as 1978, alcohol was actually used in oral sedation in oral maxillofacial surgery offices. There was a report actually in the JADA McCarthy and Hayden in 1978 that used alcohol. So regardless of the fact that we don't prescribe it anymore, doesn't mean that our patients aren't using it. There are plenty of our patients showing up to our practices self-medicated on alcohol for anxiolysis, if you would. I'll tell you why chloral hydrate is not necessarily a great idea. It's related to alcohol, and it has an active metabolite called trichloroethanol. 30 to 45 minutes for its effect. Lasts about 2 to 5 hours. The dose is 50 milligram per kilogram, and it's really a gastric irritant. The overdoses are common. It causes respiratory arrest. I've seen a child have a respiratory arrest and hypotension inside a CT scanner for CT, and chloral hydrate was the only sedative they gave. They can cause arrhythmias, especially supraventricular tachycardias and ventricular tachycardias. And there's some question about whether it has some carcinogenic metabolites. Then comes the point of, we can use opioids as effective pre-medication. Well, if the patient is in pain, sure, you're going to give them some analgesia ahead of time, and it definitely has sedative properties. And it has poor oral absorption and definitely causes respiratory depression. The abuse potential gives them a bad name. It's not necessarily always indicated as a good pre-medication, except if preoperative pain is present. And if you do need to use opioid sedation, fentanyl is the most common one. Chemotherapy units actually do use fentanyl popsicles quite a bit. Respiratory depression is a common side effect. Postoperative nausea and vomiting is rather common with fentanyl, and should be used only while being monitored. That being said, plenty of people walking around in the general population, driving trucks, flying planes on fentanyl patches. So it is out there. It is in fact something that we need to be aware of. Well, benzos come up as the most common thing that we use in oral sedation or oral anxiolysis or pre-medication. They do act to facilitate the binding of GABA. Limited action to CNS, really has very little to no cardiovascular effects. It's quite well absorbed. The drugs that come to mind are your diazepam, your Halcion, and your midazolam. Halcion is a really good drug. Diazepam is kind of like urinating in the ocean with some people sometimes. You don't even know that it's in there. They pretend like they are somewhat sedated. They really don't get it. But Halcion does work pretty well. Very rapid elimination, so the timing of actually taking the medication makes a big difference. If you do have somebody that you give Halcion to, anyone use Halcion in the crowd? You guys don't use Halcion? You should look it up. It's a pretty good drug. It's a good anxiolytic. You should have them take it in the, come an hour early to the appointment, sit in the office environment and take it there. That's quite useful. Oral midazolam is definitely something that I've used here in the past, and I tend to use it oftentimes these days. Diazepam, like we talked about, it's well studied in pediatric patients. Valium's an old friend of ours. Sorry. Benzos. The midazolam is my go-to because that comes in cherry and raspberry flavors. If anything comes in cherry and raspberry flavors, it gets on the high priority list in my practice. And so midazolam clearly takes the cake for that. It has a rapid onset of action, short duration of action, and no real active metabolites. Really comes as a liquid. Sometimes to give a big guy sitting, an adult sitting in the waiting room, a cup full of raspberry flavored midazolam can be embarrassing to the patient, while the kid sitting next to him walks right into the IV. So that can be a small point there. But it can come as an intranasal dose as well. I keep intranasal midazolam in my office, but it's if you've ever had anything intranasal, it's actually rather invasive and uncomfortable. And children typically, the child that is uncooperated to drink a cherry-flavored or a raspberry-flavored liquid is not going to find the intranasal midazolam any more palatable, if you would. So that's something to keep in mind. There is a little lozenge or a little thin sheet that you can put on the tongue of midazolam that is usually really quickly dissolved sublingually, but usually a little bit of soda helps in getting that out as well. So the oral dose for midazolam is 0.5 to 1 milligram per kilogram with a max dose of 15 to 20. And it can be given nasally or rectally. The problem is all the usual disadvantages. It does make children a little dysphoric, which is usually YouTube material for the parents, but it's a little scary when you see a couple of the paradoxic events. It has no analgesic effects and has about 3 to 4% of these patients can have paradoxical reactions. If you use ketamine in your practice and you think your patient just went crazy from having the ketamine, it's usually not the ketamine that causes that. It's usually the midazolam that causes the little craziness that children come out with. And that's not unusual for children to have paradoxical reactions to midazolam. Halcion. The thing with Halcion is if your patient likes grapefruit juice increases the area under the elimination curve about 40% and can significantly delay recovery for patients who have Halcion. The peak levels don't really increase significantly, but I like Halcion since it's a slower onset but wears off at a good rate. It just sits there and makes the patient a little chill while you're about to get them in the chair, and then it adds to the actual sedation itself. Presidex nasal spray. Presidex, I've used Presidex now for a couple of months now, actually probably close to a year now. I like Presidex. I don't necessarily like Presidex nasal spray or oral syrup. Presidex just became non-form, it became generic, and so its cost went from like $50 a use to like $5 a use, and all of a sudden it became attractive to oral maxillofacial surgeons. And I think there's a really good drug here that we could add to our armamentarium. It's an alpha-2 agonist, and so it's nothing like anything we use currently. It's not like propofol. It's not like benzo. What it does is it's gaining popularity because of the fact that it does not cause a decrease in respiratory drive, and it makes the patient really sedated. So this has become the go-to drug in awake nasotracheal intubations in the operatory setting, where patients are kept sedated, but they are not losing their respiratory drive. So this is there's actually an app for Presidex that helps you with all the dosing for Presidex in whatever form you want to give it, whether it's intranasal, intraoral, or IV. It usually requires a propofol pump-like pump, but you can easily take your old Baxter pump and turn it into a Presidex pump. It doesn't require any kind of big technological stuff. And of the residents in the audience, have you guys used Presidex on anesthesia service? Okay, you should, if you are on anesthesia now or you have juniors on anesthesia, you should push them to try to use this drug and get used to it, and that way when they come back to your service, they can learn how to treat your patients with these and teach you how to use it too. It mimics natural sleep, anxiolysis, analgesia, sympatholysis, and minimal respiratory depression. In fact, there's talk about using Presidex in intercontinental flights to allow pilots to catch up with jet lag, induces natural sleep, and gets them going. How many people use the IM technique? A lot of people use the IM technique. So the dot, right? The dot of ketamine. It's the dot that's a horrible, terrible, disgusting dot that I will never give my own child. I used to do the dot all the time until a couple of years ago I stopped doing it simply because it's to me the advantages are clear, that it has the predictability of onset and definitely gets things going for most uncooperative children. But the problem is that it is one big boo-boo, and that one big boo-boo is, the rapidity really depends of the onset really depends on the drug and the site. And you are taking a child who's already crying and now poking him real hard and making his unpleasant experience a really unpleasant experience. So there is all of that. The drug that is mostly used for this is obviously ketamine. And ketamine gets a bad rap because a lot of people don't trust ketamine, because we used to use it to sedate the animals at the zoo. Is that what we're really doing to our own population? No, that's not really true. Ketamine is a great drug. I use ketamine almost daily in my practice. It causes what's called dissociative anesthesia. It's a potent analgesic. In fact, I've stopped using fentanyl as a routine for all of my sedations. If I'm using ketamine or Toradol, I don't give them any more fentanyl. It does have some amnestic effects. It dissociates the cortical and the limbic systems, and so it disrupts any kind of interpretation of any kind of painful stimuli. So if you take a hammer and go towards them, they'll stare at you. They had ketamine, but they're not going to fight you. What we do is the doses that we give, and there are good studies out there that show that about half per kilo is all you need in an adult for ketamine to have its effect. And that is a good subanesthetic dose. It provides great analgesia without any respiratory depression. And it certainly decreases and reduces the patient's narcotic requirement. It does stimulate smooth muscle dilation, so it's less risk for bronchospasm, especially in those asthmatic patients that may come your way. It does increase salivation, although in the doses we use, it's never going to drown our patient in saliva. It causes a slight increase in heart rate and blood pressure. In patients who have pre-existing blood pressure in the older population, I don't use ketamine. In patients who have a ventricular peritoneal shunt or a history of seizures, I don't use ketamine because of the potential for increasing ICP. Now, the bad press that ketamine gets is because of the emergence delirium that patients complain, or more than the patients, the practitioners complain of. And the fact is that there are predictable risk factors for patients who are on ketamine that might have emergence delirium. And those two risk factors include the female gender, age greater than 10, underlying psych disorder, a high dose of ketamine, IV route of administration, and excess noise stimulation upon emergence. It is, of course, reduced if you add midazolam prior to giving the patient ketamine. And it goes without saying that it's usually the course that we take. And that's your typical cocktail. The problem with the IM dose is this. I don't know if those of you that use the IM dose of ketamine add the midazolam and the glycopyrrolate to that. I do. And so if you take a 30-kilo male, now you're thinking about 3 milligram per kilogram for just ketamine, and then you're adding 0.05 milligram per kilogram of midazolam, and then 0.005 milligram per kilogram of glycopyrrolate, which of course, because it's so expensive, we don't use it anymore. But still, it becomes a big syringe. All of a sudden, it's a big syringe, and you're giving all of that to the child. Now, oral doses can be given for ketamine. It tastes yuck, and it typically takes a little longer for the oral ketamine to work. So you get back to the IM dot, and the IM dot has some logistic issues. The first thing you need to have and worry about is the fact that there has to be a cooperative adult. If it's a super sensitive mother and you're going to hit her kid through the jeans into the kid's thigh with a big-ass syringe, you're going to be really causing some turmoil with the mother. You have to have prepared staff, because the staff can get really freaked out as well. And then, of course, in your busy office, you have to find that quiet, dark room. And, of course, be prepared to redose or start an IV. And well, this is what we don't have. I don't have patience to wait 30 minutes for that thing to work. I want that mask on and mask off. And that makes it easier if you don't necessarily do it. Then the other logistic question is, when should the monitors go on? If I put somebody, if I give somebody an oral midazolam or an IM dot of ketamine, and a kid is still in that pre-op area, am I going to put some monitors on them? How am I going to know if this is indeed going to cause significant respiratory depression or not? How often am I going to check on them? Am I going to have one of my assistants sit by them? I don't know. So drugs in the waiting room or a quiet pre-op area, can we put a monitor on that kid who's not quite there? You know, transfer to the operatory when cooperative is the most practical thing that all of us do. And as soon as they are seated and they're a little bit more cooperative, you can put the monitors on. I don't necessarily care as to when the monitors go on. I think it's more prudent to have the monitors on until they're ready for discharge. And ready for discharge is something that you as the practitioner should decide, and not a dental assistant or an RN who is monitoring for you. That's a decision you must make yourself. So how do we avoid problems with this kind of stuff? You schedule appropriately, you expect some delayed recovery. Of course, there's some medical legal issues associated with signing consents at pre-op appointments, because, you know, what if they came in, they didn't have a signed consent with them, and all of a sudden you've given them the pre-op medication, and then your assistant says, oh my God, we forgot to sign the consent. And now you got a slightly drunk patient, not necessarily a child, but an adult, that needs to sign a consent, and that consent may not be valid at that point. So, of course, then we talked about the patient, the parent, and the pharmacist. The pharmacist is important in this because sometimes some things have to be concocted. They have to be mixed together, such as, you know, a flavoring, for instance. You can't compound these things yourself. You may have to have a pharmacist, and they may question why you're doing this in the office, and could have all kinds of issues with that. What about parenteral therapy? So if we move on to parenteral, I hope nobody practices rectal administration of medications in our specialty, and most of us talk about intravenous and intramuscular. Talked about intramuscular already. Let's talk about intravenous. The advantage, obviously, of an intravenous medication is that it's quickly on and quickly off, and it's kind of sort of fairly predictable. The disadvantage, of course, is that it's a poke, and one more poke, and then the patient turns to bite you. And then children, of course, have the peripheral vascular challenges and compromises. Now, what fluid do you use? You know, do you use D5 half? Do we use D5? Do we use 0.9%, or do we just use normal saline? It doesn't matter what you use. At some point, you know, you just need to be more cognizant of what how much you're giving the child as opposed to what exactly you're giving the child. Technology has made things so much easier that if you're worried about dose calculating for any kind of pediatric sedation, there is this app that I use. It's called PediStat. I don't own it. I don't get any money for anyone using it. Disclaimer. But anyway, this is about an $8 app, but it's actually a really good app. It gets on there, and you can actually figure out what exact dosing you need for everything. You can customize it to things you typically do. This is for a pediatrician, but you can just make it your sedation app, and you know, you get in there and you can give whatever you want to give and take it from there. And this app can sync to your electronic health record, or you can text it to your nurse who's drawing up medications for you, whichever one you want to do. So the drugs that children can receive, we're going to talk about a couple of these things, understanding that, you know, that anesthesia is all about a little balance between anxiolysis and amnesia, analgesia and immobilization, sedation and hypnosis. It all needs to be done within the realm of safety, and that's where it becomes the art of anesthesia. But you can't do the art of anesthesia unless you know the science of anesthesia, which I think is important. So we're talking about drugs quite a bit here, and these are some of the drugs we talked about. But I want to specifically talk about inhalational anesthetics. Inhalational anesthetics have really changed the way that I practice pediatric anesthesia. I see about, let me put it this way, about 62% of my practice is children under the age of 15. And that's not by choice, but that's by default, that none of my partners want to see kids. And a lot of these children have Ohio Medicaid, and me being in the Walmart of Medicaid care, my doors are always open and my prices are always low. And so by default, these children do make their way into my practice, and I need to somehow find a way to get them all sedated so we can do the simple procedures. If I had to take all these kids to the operatory, that would be not only a drain on resources and my time, but also a total waste to society. So I have to do this in such a way that I can do it safely, I can do it economically, and I can do it in such a way that I can teach the next generation of residents that train with me how to do it the same way. The advantages of inhalational anesthetics is the fact that, one, you can buy a slightly older machine on eBay, which is what we did, although we are in the hospital system, and you get the biomedical engineers to come and certify it for you. It's as good as new, and it won't cost you much. And then the only drug you're using with that is nitrous oxide and oxygen and sevoflurane. And the advantage clearly is the cooperation you can get with a kid. You play a little game with the children and you preempt them towards that. You tell them that, hey, listen, when you come back, we're going to play a little game. We're going to put a little space mask on your face, or we can go scuba diving, depending on what they want to do. You'll have a funny smell that comes through, and that's because of the hippos in the zoo that is next door. The hippos fart quite a bit, and the fart air gets in the hospital stuff, and it comes out and it smells funny. And they start giggling, and then the nitrous is on. And finally, you show them the little balloon, which is the ambu bag, and you make them blow into it in and out, and they go off to sleep. Now, that's quite predictable 90% of the time. And it's fairly rapid onset when it comes to that. But for that one child that doesn't like to sit there, you can talk about crying, because crying is actually okay. Crying helps. They take big, deep breathing, and that gets the gases into them rather quickly, and that gets them asleep much quicker than trying to go through the fairy tale. The disadvantage, obviously, is that sevoflurane, despite the fact that it is considered pungent and tolerable, has an offensive odor, and the acceptance of the mask sometimes can be a problem. I treat a lot of autistic children in my practice. There's all kinds of autism, and in the spectrum of autism, some children just don't like the fact that something touches their face or something smells bad, and that can be a real problem with some of these children. And it definitely does get them a little closer to a laryngospasm unless you are a little bit more careful with these. So nitrous oxide and sevoflurane have become my go-to. What size bags do you use? I use all three, depending on the size of the children that sit in the chair. And then, of course, I have a micro drip and an infusion pump in the room. I rarely use the Bertrol because I don't necessarily find it useful. I'm very careful, especially in the small children. You don't necessarily need the micro drip, but it's usually useful to be quite prudent and cognizant of how much fluid they're getting in what they're in your office. Nitrous oxide has been proven to be safe since 1844. Few side effects in the pediatric population, rapid induction, emergence, insignificant cardiovascular respiratory changes as analgesia added to it, and it does provide that second gas effect. So I usually start with 100% oxygen, then I dial in the nitrous and I tell them my bad jokes. My bad jokes typically are just two of them. I only know two clean jokes, and those clean jokes I quickly run out of, and the kids get amused because they're getting a little nitrous oxide. I know many unclean jokes, which I unfortunately cannot use in the pediatric population. So we are stuck with the what's the difference between roast beef and pea soup? Does anyone know? The difference between roast beef and pea soup is anyone can roast beef, no one can pea soup. And that gets the chuckle out of the 9-year-old in my chair, and that usually gets things a little bit more lighter. Once we have the nitrous oxide up, we dial in the sevoflurane. Sevoflurane, as you know, is a halogenated ether. Decreases incidence of breath holding in laryngospasms, and it causes fast onset of action and recovery. It's used safely when combined with local anesthesia, has some improved patient acceptance compared to a lot of the other gases we use, and it has the least airway irritation. the single breath technique is typically used in the uncooperative child. The child is already in the chair, rather uncomfortable, and you don't really have time for roasting beef or peeing soup. So what you do is you turn on the nitrous and you turn on the sevoflurane to 8% all the way up, and you hold the mask on them. They might start crying. At that point, they take a couple of deep breaths and they're out, and then you can dial down as you need. But in the cooperative children, the mask induction typically happens with a single breath technique, which is an incremental dose that is increased every 3 to 5 breaths of 0.5% sevoflurane, going all the way up to 8, or you don't necessarily often have to do that. In the real small children, in the real big children, and in the children that I suspect I'm going to do procedure a little longer than usual, I always place an IV. I always place an IV. And if you are in doubt that you may not be able to get an IV placed in this child, when the time comes for it, you're better off placing it right at that time when stage 2 is done, before you start that procedure. That is your safety valve. That is where, if you need to give them a little bit of atropine at the time that they're starting to brady down, that if you don't have that IV, that's when things go south. That's not necessarily a good thing. The most important drug in all of pediatric sedation is local anesthesia. Unless you have the kid nicely numb, you're not going to get anywhere with this. But beware of how much local anesthesia you're going to give, and we'll talk about local anesthesia toxicity here in a minute. The vascular access is key. I think if you don't have 22 gauge IVs in your office, you should stock some, especially if you're treating children. If you don't have an IO, you're probably better off getting one just in case you need to use one. In case you can't start an IV and you have an emergency, you definitely need to get some kind of a safety net, and that's your IO. Those kits are less than $100. They don't expire once you buy them. You buy them and you keep them, and occasionally you can practice them during your simulation drills. It's quite useful. It just makes me feel better that I have that alternate in my office. The other techniques, obviously, like we talked about, the intranasal and the transmucosal, there is rectal anesthesia, but it's not necessarily something that we will talk about. The confounders in anesthesia. Now, don't assume that children don't drink alcohol. If parents drink alcohol and they have a lot of alcohol and they're used to seeing parents drink alcohol, a teenager can sometimes be taking a swig once in a while. The underdose of, medication. So if you wrote somebody for some Valium or some Halcyon, and they say, you know what, I lost the prescription, or I couldn't find the one pill, or the dog ate it, or whatnot, they probably sold it, and that happens. And sometimes what happens is the slightly older child, that the mother has had some experience with her anxiety in the past, might double up on the medication that you gave them. Instead of taking one Valium in the morning, they'd have taken 3, just in case. I might, just because she didn't do that well with one Valium last time, I gave her mine and her father's too. So, the question then becomes, once you have an IV, how much more of whatever medication can you give? Because they've already consumed more than what you have attempted to give them or planned to give them. And so how does that play into your sedation plan now? The other confounder is the fact that 6 to 9% of the general population have ADHD or ADD. And the medical therapy of these include some of the non-stimulants, such as Strattera or Clonidine, which are also sedative medications by themselves. So if you have a child on Clonidine who's also taking Ritalin and Vyvanse and Concerta and Adderall, everything else, how does that play into your sedation plan? How is their response if somebody's on Clonidine already and a little bit more sedative to start off with? How is that going to make a difference to how you're going to give, and how is the additive effect of every drug you're going to give play out on the child? These are things to remember. 77% of all oral maxillofacial surgeons in practice have ADD or ADHD. You knew that, but you didn't pay attention to it because you had ADD. ADD management strategies include nitrous oxide. Using nitrous oxide is quite distracting to children. Usually their phone helps. or an iPad helps, especially with children with autism. I encourage them to bring their phone and iPads. Children with severe ADD, typically not a problem if they want to watch something on their phone until the time that they're out. So you can hold that mask on their face, and this typically happens in pediatric hospitals all the time now. They have these patient care specialists who are basically iPad holders that are paid benefits and salaries to hold iPads for children while they're having all kinds of therapy, including their bones reset or a suture placed or emergency room nebulization, whatever it is. But this is a real deal, and it does help quite a bit. And of course, getting the patient involved in the induction process helps quite a bit as well. Now, I usually recommend that every patient takes their morning dose of whatever ADD medication it is that they take, whether it's a stimulant or a non-stimulant, doesn't matter. If they get their attention a little better, that's probably best for your sedation anyway, as opposed to them being all over the place. There is a question whether early exposure to general anesthesia does cause childhood ADD. That's not necessarily true. The nice paper, big analysis of about 17,000 patients in pediatric anesthesia a couple of years ago now, showed that they looked into nationwide retrospective matched cohorts to see if there is an risk of ADD and exposure to general anesthesia. Their conclusion was that exposure to general anesthesia before the age of 3 years was really not associated with ADHD. What about presence of parents in your office while the child is being anesthetized? How many people in the audience allow patients' parents to come to the office when they are sedated? I do too, but I gave a lecture, a very similar lecture the other day, and somebody brought up the issue of the legal implications of parental presence. I think it's beneficial to the child. I think the child feels a little bit more protected in the presence of their child, in their parent, and the parents are also prepared to see, oh, okay, they're going to sleep, they're going to be groggy when they wake up, and this is the guy who's doing it, and here are all the other people doing it. The problem is this legal implication. So the mother gets invited by the nurse to accompany her son into the ED, upon which she fainted in the treatment room. The mother fainted and hit her head and sustained an injury. And guess what? She sued the hospital over that. And the Illinois Supreme Court actually, the verdict read that the hospital that allows a non-patient to accompany a patient during treatment does not have a duty to protect the non-patient. However, if a medical personnel invite the non-patient to participate in treatment, the hospital has the legal responsibility towards the non-patient. So the next time you invite your patient's mom to come into the operatory with you and watch their child go off to sleep, you have just invited trouble into your operatory. But the problem with that is, yeah, there's that, and then there's common sense. If my child was going to sleep in a dental office, I want to be there when my child's going to sleep. I feel that, of course, I'm not going to turn around and sue the dentist if I fell and hit my ankle or something like that. But that doesn't matter. But this is the world we live in, and be aware that this is out there, and there is a precedent to this. So just bring it up there that if you have a practice where you bring the mother back or the parent back, there is a good chance if they faint and hit their head. What about the child that has a child? We talked this morning about the 19-year-old sexually active female, but now we're talking about adolescents between the age of 12 and 21. Should I ask about this? Should I assume that every postmenarcheal child, girl child, could potentially be pregnant? I don't know. I have 2 girl children. I would hate to think that this question is being asked if my children needed to have surgery. But then the truth is that incidents of pregnancy that were discovered in an ambulatory surgical center in that age group was 0.5%. So that does happen out there. how do you assess? Do you get the pregnancy test? Do you document that last menstrual cycle like we talked about this morning? I think that is the key. You can definitely ask the mother about a couple of questions. You can ask the child. It's in a slightly older child, but don't be naive to these realities that are out there. And in fact, if you proceed with the anesthetic to say a 15-year-old that happens to be pregnant but not telling you that they're pregnant, the risk is, of course, the risk to the fetus of teratogenicity, preterm delivery and asphyxia, but also to the mother. There's a difficult area. There's aspiration potential. There's hypoxemia. There's embolic phenomenon. All those risks associated with pregnancy don't go away just because the mother is a child. The anesthetic neurotoxicity has clinical implications in the animal model. So exposure to anesthetics and subsequent learning disabilities has been proven. The problem is, while we know that this does happen in the animal model, we don't know what will happen in the human model. We do know that there is some inhibitory effects of some of the medications we give, and that activity can cause significant problems in the late pregnancy. The other issue is the age at the time and duration of exposure. The problem is not necessarily our patients, it's also our assistants that work in the SIVO suite, the nitrous oxide suite. They're young women of childbearing age. They don't find out they're pregnant until 2 months later into their pregnancy. By then they've been involved in multiple SIVO inhalational anesthetics with you. The risk is there. It's not unreal at all. The comorbidities matter too. Typically, as a rule, avoid sedation in children under 3 years of age in your office. So what time is it? It's about an hour since we started. We could take a 10-minute break here and come back if that's what Joe would like. Is that okay, Joe? All right, we'll come back in about 10 minutes or so. 10 or 15 minutes, then we'll finish up with the pediatric anesthetic emergencies, if that's okay. Our lecture by webcam. They're on a break right now, so I can see them. I can see them, and then when I hit present,
How big are we on the screen right now?
We're huge. We're huge. Dude. Let me toss the webcam.
What's your lecture over? Surgeons.
Huh? What?
What's your lecture over?
Anesthesia. Medicine and
Freak out.
what's the happening in the Boston? text you as soon as I'm done. So.
All right, we're going to get started. Deepak, can you hear me?
Yes, sir.
All right, on the home stretch.
Okay. It's so nice to see the crowd dwindle as the day progresses. But I don't blame you. This is so difficult from far away. But thank you guys again for coming over and spending the day here, whatever your motivation might be. Nate Spencer, one of my former residents, is sitting in the crowd, and I had to, I know what his motivation is. I had to threaten him to be there today. But anyway, so we're going to talk about management of pediatric emergencies in the oral maxillofacial surgery office and how that pertains to our everyday practice. And I think that's important, not only we need to talk about safety as it relates to how we treat our patients, but also state certification requirements often require us to audit our own practices. It definitely impacts our malpractice costs and impacts us as a whole, as a specialty. But you know, the advanced, safer sedation monitoring technique, and the more we train and practice our training, it's just the fact that, you know, you sometimes become the one guy that gets all the children to treat, and somebody's just got to do it. You have to do it the right way. You have to do it the right way every time. If you look at the adverse events in outpatient setting, Pediatric Sedation Research Consortium, it's not a very common place that something really bad goes wrong compared to the number of anesthetics that are delivered. So the majority of people who provide anesthesia service do it well and do it properly. And the chance of an adverse event is quite low. Well, there's vigilance at every step that one needs to take care of, and that's where everything starts with patient selection. Is your office prepared to deal with this kind of emergencies? Are you taking in the right kind of patient to your practice? There's vigilance at every step that is related to pre-procedural vigilance. We talked about a documented pre-sedation medication eval, including a focused airway exam, an appropriate interval of fasting before sedation. We talked about no sedative or anxiolytic medications without supervision from skilled medical personnel, not at home or not by a technician, in your office. Sedative and anxiolytic medication should only be administered by or in the presence of individuals skilled in airway management and CPR. What about procedural vigilance itself? You're the one delivering anesthesia, you're the one providing anxiolysis, and you're the one doing the procedure. Make sure that you have everything within your reach. Age and size appropriate equipment and appropriate medications. Be aware of the dosing for these appropriate medications. That is based on the patient's size and age. Continuous and appropriate monitoring as per your state's design. Designated anesthesia personnel to monitor the patient's cardiorespiratory status during and, more importantly, after the procedure. After the procedure, have very specific discharge criteria. Children sedated using medications with long half-lives such as chloral hydrate or pentobarbital or chlorpromazine is important to keep them a little longer, a little extended observation. Don't hurry that discharge. And as a rule, in my practice, parents who bring a child for an anesthesia get two preoperative instructions. One is the fact that they need to be NPO for that 4 hours to 6 hours, and the other is that they need to have 2 adult escorts with them. And it's very important to me, and I tell them always that it needs to be 2 adult escorts in the same car. Because sometimes you ask for 2 adult escorts and the separated parents show up in 2 separate cars and they go their ways, and it kind of beats the purpose. The point of having the 2 adults come in, responsible adults come in, is the fact that if the child is sedated and continues to be in a bit of a post-anesthesia delirium, sitting in the back of the car, either nodding off and falling asleep and aspirating, or throwing up and aspirating, and the mother is the only one in the car driving on the freeway, it becomes a practical problem for her to stop and help the child. So I always ask for a second adult, or at least an older child, to be in the same car with the patient. And sometimes I have to get into a little bit of an argument with some kind of a defiant parent that says, why? Why the last guy didn't do that? Why should you? And then I have to explain to them it's for their own safety that I'm suggesting that, and they should probably listen to what I'm saying. Vascular access. We talked about vascular access, about having IV skills, having the IO availability and training and use, and having that as a safety net in case things go wrong. Even despite all of this planning, it's despite the fact that everything's set the way it should be, sometimes you get the unanticipated adverse event. And sometimes whatever you do doesn't go well that day. It does help to be a little organized in order to prepare for such a day. And what I do is I actually use this little box. It's called 10 Minutes Saves a Life. I don't know if anyone's seen this, but this is something that actually you can buy through ADSA. ADSA sells this, I think, $60 or $80 or something like that. What it does, it opens up and it's got these preset little module-like packaging, and you can put all your emergency drugs for your pediatric sedation or your adult sedation, for that matter, into that little box. And you do it and you look at it every day or every other day, and you kind of know where your epi for your for your ACLS drugs are. You kind of know where your Benadryl is. You kind of know where everything else is nicely organized and kept. I think it does a good deal with when it comes down to organizing it and sorting it out. Even if you don't have this little box, it's fine. It just helps to have your way of organizing your emergency medications, for instance. As you calculate the dose for sedation medications, you want to pre-draw IM doses for the procedures and have the IV meds in the room. And I typically have 2 meds that are drawn up for the day, and I waste them if I don't use it, and 99.9% of the time I don't use these medications. They're cheap, they're pre-drawn, and they're kept there with the syringe taped to the actual bottle. And if I need to, I have it there. It's the cost of my safety that I do. When you treat children and when you hear all these bad stories going around all over the country and abroad, you are on guard all the time, and it's important to kind of step into that and play that game a little bit better than anyone else that's doing this. So your emergency drugs include your SUX, which you know as the depolarizing muscle relaxant, 30 to 60 seconds of onset time, duration for about 10 minutes or so. Children are much more susceptible than adults. If you give them succinylcholine, a slightly higher dose can cause cardiac arrhythmias, hyperkalemia. Of course, you know, this is one of the medications that can trigger your malignant hyperthermia, can cause rhabdomyolysis, or actually just muscle death in the area of where you give it, if you're giving it IM, for instance, myoglobinemia. All of these problems do occur, but occasionally you have a larger child that you have a severe laryngospasm with, and you're looking for some SUX, and you have it right there. What are the drugs that you can give through your ET tube? That's your naloxone, your reversal, your atropine, Valium, Epi, and lidocaine. And it's important to keep that in mind, the little checklist there for you. This checklist is also your IV medications for your emergency drugs, and these are the pediatric doses that I typically have on hand. This is in my little box, and I keep it separate for the adult and pediatric. I have a separate crash cart, but this is my go-to if something goes wrong, like an allergic reaction, for instance, which is what we'll talk about now. So anaphylaxis is an exposure to an agent, usually without any previous history, whether that be antibiotics, latex, or often preservatives in medications that you never thought, as opposed to angioedema. Anaphylaxis can be mild or it can be very severe. So when you think of anaphylaxis as an emergency, you must always think about it as, is it the itch and the flush, or is it something causing cardiovascular compromise? So if it is the mild to moderate, there's pruritus, there's flushing, urticaria, edema, usually around the mouth, some conjunctivitis, it looks like seasonal allergy. But the severe one that causes cardiovascular collapse and can lead to death can also occur in the office, especially in children. How do you manage that? You, of course, have to figure out which offending drug or material is causing it and remove it out of the harm's way. And then give them some Benadryl, some bronchodilators, possibly steroids. This cardiovascular collapse, immediately reach for the epinephrine. So in my mind, anaphylaxis falls into 2 categories. You know, you got your cardiovascular collapse and the one without the cardiovascular collapse, which is just an allergic reaction. If you've been through enough pediatric anesthesia lectures, there's a good chance you would have seen this particular slide. It shows the edema, effects of edema on the airway resistance of a child versus an adult. This being an adult, if that is the circumference of somebody's airway, having just about that much edema can cause about 3 times a decrease of about 44% of the total circumference of the trachea, whereas the child's trachea, which is about half the size of that, with the same amount of edema, causes 75% decrease in the cross-sectional area, and that's typically what happens in anaphylaxis in children. Real problem, happens more often than you think. You've got to be prepared for it. In fact, if you do simulations in your practice, your clinic, or your residency program, you should simulate going through a scenario where there's anaphylaxis with and without cardiovascular collapse. You'll be surprised as to how many people reach for the epi and it's the wrong dose and they end up giving that and killing the patient too. Aspiration is real common. It does occur especially in patients with GERD, obesity, hiatal hernias, and pregnancy, and of course trauma patients with a full stomach. So the increased abdominal pressure and intragastric pressures is a culprit in the large patient, for instance. GERD and hiatal hernias are common in these patients. But when you consider, like we talked about this morning, morbidly obese patients have a decreased gastric emptying time. And so the 8-hour fast is probably sometimes not enough. Sometimes you have to put them on an H2 blocker and a prokinetic agent 12 to 14 hours prior to surgery. And that could help quite a bit as well. The sequelae, of course, is the problem related to the aspirate and the level of anesthesia. There's aspiration pneumonitis and there's actual aspiration pneumonia. Of course, it can cause physical obstruction, as in a peanut or a strawberry or a piece of cocktail sausage getting stuck in somebody's larynx. And it can cause laryngospasm, which would be protective in this sense, and bronchospasm, which would be reactive in these cases. And should that happen, the treatment should be, again, dependent on the pH of the aspirate and what level the anesthesia was when the patient actually aspirated. If the reflexes are intact and they can cough, they turn their face to the side, head to the side and give them some oxygen, suction out the chunks that are coming out. If you can't clear the airway, place the patient in a head down Trendelenburg position, 15 degrees, and turn to the right, suction up, potentially consider intubating to protect the airway. Of course, the one thing that I've learned over the years is a direct laryngoscopy really is much better in looking for stuff as opposed to video laryngoscopy. Even your glide scope has a wider base of that blade, and oftentimes what will happen is small particulate material, especially food debris, can get caught really under the blade of the glide scope as opposed to right under a smaller blade, as in a direct laryngoscopy blade. So that's a real learning point for me, that direct laryngoscopy was often better than video laryngoscopy itself in patients with aspiration. Of course, you maybe have to be prepared for cricothyroidotomy or tracheostomy. I'll never forget the time when I was a second-year resident in Atlanta. There was a time when all the attendings were gone to the Amos meeting or something like that. And my chief resident and I had been doing model surgery in the lab. And around 3 o'clock in the afternoon, he said, "I feel like eating apple pie in the cafeteria." And we strolled down to the cafeteria at Emory Hospital. And as we were enjoying coffee and apple pie, this woman started aspirating. Guess what? Apple pie sitting next to us. And my chief resident ran over and attempted a Heimlich maneuver on her, only to realize that she didn't have any legs, and she was sitting on this wheelchair-like thing that fell on him and her on top of him, and that didn't really help with the Heimlich maneuver at all. At that point, the code was called, and somebody came in, and he said, "I need to do a crike on her, get me a knife." And I remember 3 objects being offered, a plastic knife, a straw, and a coffee stirrer, and I wasn't sure which of those he was going to take. At that point, the code team luckily arrived, and there happened to be a general surgery resident that came in with a real knife and cut through the lady's throat. But apple pie can do some serious damage to American motherhood sometimes. And I still remember this apple pie story when it comes to aspiration and crikes. Aspiration pneumonitis, of course, is the acute lung injury after inhalation of regurgitated gastric contents. The problem is that approximately, it happens 1 in 3,000 times anyone has general anesthetic, the body habitus usually being the culprit to be blamed. 10 to 30% of deaths associated with anesthesia happen from aspiration pneumonitis. It causes an actual chemical burn of the tracheobronchial tree and the pulmonary tissue themselves. The intense parenchymal inflammatory reaction. It's usually biphasic, which means that the first time around there's that direct caustic contact which occurs the first couple of hours right after the injury, and 4 to 6 hours later this inflammation sets in. That can be really big. It's a particularly a problem if the gastric pH was rather acidic and there was a large amount of aspirate per kilo of the patient that was aspirated. There's no real reason to give empiric antibiotics because technically all the gastric contents are sterile, but antibiotics are warranted if there's a fever and the pneumonitis doesn't necessarily resolve within 48 hours, and the pH could be higher than 2.5. Well, typically they put some these patients on some broad-spectrum antibiotics such as Levaquin. Generally, if you look at a chest X-ray, this would be the pneumonia versus a generalized pneumonitis in these patients. The pneumonia in itself is inhalation of colonized oropharyngeal material. A lot of people in nursing homes and people with neurologic dysphasias do this all the time. They call it silent aspirates. It causes impairment. It happens because in the older population, for instance, or people with neurologic dysphagia, that they lose their gag and swallowing reflex, and so they end up doing these silent aspirates. Radiographically shows these small infiltrates like we showed earlier, but generally not associated with general anesthesia. How do you prevent aspiration? Well, the best thing is to recognize patients who are at risk, and of course you could try the Selig maneuver, which has scientifically never been proven to be useful. There's RSI, which is the rapid sequence induction, which typically is utilized in the trauma bay or in trauma patients who are expected to be on a full stomach, including alcohol, to prevent the gastric contents from coming up at the time of the intubation. The recommendations for prevention of aspiration in the office procedure or in the office environment is lacking. We simply don't have any kind of evidence to prove one thing that we do is better than another. Well, if the obese patients come into our practice, it's probably okay to give them some preemptive therapy with Biceptra or ranitidine or Reglan. Or of course you can consider canceling the procedure if the patient did eat. Like I said, since Cheetos is not really dinner because your mother said so, a lot of patients do come in and eat Cheetos, and Doritos is the other thing that we do. Some people wake up at 4 in the morning and have a full meal. I don't know about that. Why would you have a full meal at 4 in the morning for a procedure at 10 o'clock? Current guidelines, 4 to 6 hours for food, 2 to 4 hours for water, works just fine to prevent aspiration. Apnea and airway obstruction. This is where a lot of things that we talked about kind of come together. So the mechanics of the anatomy as well as the physiology, and also the fact that a lot of the drugs that we give people can also induce apnea and obstruction of the respiratory system. So opioids for sure, benzos and the inhalational agents can all cause apnea and obstruction. And of course there's the mechanical obstruction of a large tongue or soft tissue, tongue retractors that we put in there, foreign objects that we throw in people's mouths. The treatment is simple as usual, jaw thrust, remove the instrumentation, protrude the tongue mechanically either with a suture or with a Russian forceps or a hemostat or something else. And the hypercarbic drive in itself get people to come out of the apnea, but often may require some positive pressure ventilation, placement of a supraglottic airway, or an intubation. The challenge is, again, like we talked about this morning, if you cannot ventilate, do not sedate. If your ability to mask ventilate in a person who is really big, greater than 26 BMI, history of snoring, lots of facial hair, obese, Mallampati score is poor, thyromental distance is non-existent, MIO is minimal, any of these things cause distortion of the anatomy, and that could be an airway challenge. Be careful, because if that's that slippery slope that we're going to go down and we can't get to ventilate the patient, you're probably unlikely to be able to intubate that patient. But what you do is you plan for failure. And you assume that everything's going to go really terribly wrong, and then and plan accordingly. So say for instance, if you are called tonight to drain somebody's abscess in the deep neck space area, and you know that the anesthesiologist that you typically feel comfortable doing such intubations with is not available, and the occasional OBGYN anesthesiologist is coming in to do your case, and they haven't done a difficult airway in a long time. So it's important probably just to identify a cricothyroid membrane preoperatively, mark it, make sure that you have the correct size equipment ready, keep a video laryngoscope ready. Just be prepared for failure. Nothing wrong with that. If you don't fail, good for you. You can go away and go home and have a beer. But if you do, then you're all set. Either way, you go home and have a beer. The inability to ventilate, in case of a procedure you're doing in the office becomes a real sticking point. You have to stop the procedure, pack off every wound, confirm the airway, confirm the sniffing position, grab the tongue and pull everything forward. The bag mask ventilation with or without the oral airways and the second generation supraglottic airways. At that point is when you start thinking, do I call 911 now? Has anyone called 911 in your offices? Anyone in the audience? I have. You know what I found out? I found out when I call 911 in the office, I have to dial 9 before I call 911. Because I'm in the hospital and no calls go out unless you dial 9. If you dial 911, you just sit there and the operator is wondering, 1-1, what's going to dial next? So the 911 needs to be dialed with a 9 in my office, and I found that out the hard way. And of course, we were doing a simulation drill, and I got into trouble for calling 911. I just wanted to see how long they'll take to get to my office in case I really have to, and I had cookies ready for them too. But if you got to try to intubate the patient, don't take too long to intubate the patient. Try to place that supraglottic airway, and you're probably safe doing that. Don't need to go any further from there unless the patient has a severe cardiovascular event at that point, and then you need to definitely call 911 and move the patient to a hospital setting. So there is some scope for doing some transtracheal jet ventilation. I don't have the equipment in my office. I'm not going to attempt it. I don't feel comfortable doing it. If I have to do a surgical airway, I'd be happy to do that, but I'm going to try not to do that under any circumstances until I get to that very point. Stop all kinds of inhalational agents. If you think you gave them too much Narcan, too much opioids, give them a little Narcan. Reverse the sedatives of all kinds, see how they do, and then take it from there. The problem, of course, is hypoxia. And hypoxia comes from all kinds of ways. You could have mechanical reasons why somebody is hypoxic. It could be an intrapulmonary issue, and it could be a surgical issue that you're causing hypoxia. Either way, what you need to do is treat it with 100% O2. If you didn't catch that, treat it with 100% O2. The obstructed ET tube, if you have one, or a ruptured ET cuff, if you had placed one, sometimes it's a false reading on your pulse oximeter. Sometimes it's a circuit that came disconnected. And sometimes it's just you not knowing how to place that ET tube properly. These are the reasons why they could have potential mechanical hypoxias, mechanical reasons for true hypoxia. This is, of course, in case you did place an ET tube. Intrapulmonary reasons why there could be hypoxia can be much worse. So you want to know that it is a laryngospasm, not a bronchospasm. Bronchospasms are really bad. If you've had a bronchospasm, it feels like you're trying to push air against a brick wall. It's terrible. It's terrible. And once you have that going, you could potentially also have costopneumothorax. That's easy enough to find, and that's actually easy enough to treat. All you need is to ask for a stethoscope and listen for breath sounds. But the laryngospasm is probably the one thing that happens to you more often than anything else and causes hypoxia. So, but because you have all of these things in your head, and there are so many things that could potentially go wrong, how do you figure out, how do you troubleshoot what just went wrong? It doesn't matter. Remember, 100% oxygen is the cure for hypoxia. All you need to do is establish adequacy of ventilation right after. Get everything out. Hand ventilate the patient. If the patient's not intubated, just hold the mask real tight and ask somebody else to squeeze the bag for you. If the patient's intubated, take him off the ventilator and then do the masking yourself, bagging yourself. And then as you're doing that, it's like, going to the the vending machine when you were on your ICU service and thinking about all these things that could have gone wrong before you go and hit that code that you were just called to go join. So similarly, you can assess all the variables while you are bagging and masking the patient. At least you've got the oxygen flowing for you. The clues usually in your physical exam. The clues usually on your capnography and figuring out why your FiO2 concentration is. And typically, you know, it's one of these things. It's obstruction, it's a bronchospasm, or a tension pneumo. Can you hear? Can you hear bilateral breath sounds? Are the breath sounds decreased on one side versus the other? Are the breath sounds clear? Just get your stethoscope out. You still have that thing somewhere in your office, you know. Is there a leak in your circuit? If you got the tube in and it's still hypoxic, think about that. That circuit can be a reason. Anytime you add any variable into the equation to treat something, that could potentially go wrong. So if you did intubate the patient or put an LMA in and they're still hypoxic, look at the circuitry itself. Is the oxygen tank low? Maybe go and get that standalone that oxygen tank. Check your pulse oximeter. Perform a laryngoscopy. See if there's a kink in the ET tube or if there's a plug in the ET tube. If in doubt, just change that system out entirely. Sometimes it's just faulty machinery and you find that out and you change that out. Sometimes it's a tension pneumo. Ask for a big needle and decompress it and call for 911 to take the patient to the emergency room. Sometimes it's just a dislodged tube that you thought was in the right place. Anemia, hemorrhage, blood, IV fluids, all of these things can also figure into hypoxia. So we may need, you know, some PEEP or a PA catheter at that point if everything else looks good for further diagnosis. Now, laryngospasms, we treat laryngospasms like it's nothing at all, but it's actually a big deal, and we shouldn't take it lightly. Sometimes things can spiral down much worse from a laryngospasm that's managed poorly. I have the privilege of piloting a lot of the simulation workshops that Amos is putting together for bringing on to the membership at large. So all those office anesthesia evaluations that we currently do and have one of our colleagues come and inspect our office, all that will slowly go away and be replaced by a simulation training. And one of the things that we do in our practice now is every 3 months between the two facilities where I practice and teach residents, we have these drills. We have emergency drills. We have a rundown mannequin that doesn't have any legs or hands or anything like that. We have a UC Bearcats t-shirt on it. We take it into the waiting room. We do CPR on it there. We take it into our operatories. We put it on our dental chair and we give it oxygen and we make it go through laryngospasms. But even to the youngest guy in the crowd, we are going through this whole drill of how to treat a laryngospasm. And they need to understand that. This is the one thing that we need to be able to manage without having to call 911, and we need to do this really well. Laryngospasm, as you know, is a spasm of the vocal cords, and it could be partial or complete. Usually it's from direct airway stimulation, things we do to our patients. We make them bleed and we make them secrete into their airway, and then we don't put a tube down there to protect it. So, but people with GERD or irritable airways are at a higher risk, if you would, for laryngospasms, and they usually occur in lighter planes of anesthesia. So the key is to recognize it. A partial laryngospasm is usually a stridor. Patient starts to desaturate. Complete laryngospasm is when you feel the brick in your pants and you know there's no air movement at all, no breath sounds whatsoever, and patients completely desaturate. Typically, luckily for us, whether we do it or not, despite us, patients do get better, usually self-limiting. All we need to do is support the ventilation, give some positive pressure ventilation with 100% oxygen, deepen the anesthetics, and be prepared to give some muscle relaxants. In partial laryngospasms, it's probably best just to stop at deepening the anesthesia, providing the partial pressure, the positive pressure ventilation, and patient will come back to saturate, and the laryngospasm will break. If it doesn't break and the patient proceeds to having a complete laryngospasm is when you consider giving them succinylcholine. Hopefully by then you have already deepened the anesthetic and that's already helping. If it persists, then consider giving the full dose of succinylcholine and consider getting the patient intubated. Now for those residents that are in the audience that will be taking your oral boards and things like that, you know, you should probably go through, when you start preparing for your board examinations, find a study partner and go through these scenarios. For instance, in the medicine anesthesia section, all these things we talked about this morning, for instance, what tests would you do? What consultations would you send the patient for? How would you manage a laryngospasm? How would you tell the difference between a bronchospasm and a laryngospasm, etc., etc.? And then once you start verbalizing it, even if you know the stuff in your head, sometimes it's not easy. That doesn't come out. You can see the board examiner, you sit there and you see the wheels spinning. This kid knows what they're talking about, but he can't talk. And that becomes a real problem. That's why you need to practice talking to each other. It also helps in communication and social skills, you know. There are more things than just the phone screen in front of you. And then, so if this does persist, you consider intubating the patient. So just simply going through these steps will help you get past your board exam as well as life. So here's a negative pressure pulmonary edema in those robust, real strong young men that have a laryngospasm. Sucking against that closed glottis increases the intrapleural pressure significantly. What that does is it increases transcapillary hydrostatic pressure, causing pulmonary edema out of nowhere. It's a real problem because it does result in right ventricular distension, leftward shift in the intraventricular septum, and decreased left ventricular compliance. And what you see is that microscopically, fluid is leaking from the capillaries to alveolar spaces and interstitium. There is hypoxia, but the patient starts frothing at the mouth. Pink frothy sputum comes out, becomes stridorous. And you notice that they're using their abdominal muscles and their diaphragm, and all the accessory muscles are being used to try to breathe heavily. The wheezing progresses as the patients go through this. And if you've got a chest x-ray on them, it's full of froth, a lot of pulmonary edema all over. Of course, you know, that's your normal, that's your frothy chest x-ray. You treat it with 100% O2, remove the obstruction, intubate the patient, may have to give them the succinylcholine. And of course, you know, I don't keep Lasix in my office, so the treatment does include giving Lasix and getting the pulmonary edema down. If you're putting Lasix in a sedated patient, you've got to put a Foley catheter in. I certainly don't keep a Foley catheter in my office. They're better off transferring the patient to a care facility where they can manage all of those things. That's when you bite the bullet and call the 911. Of course, you know, correcting the hypoxemia and making sure that everything else is situated before they are transferred is important. The treatment of the pulmonary edema is rather secondary in all of this procedure. Bronchospasm is scary. If you've had it one time, you'll never forget it. It's a real problem in patients with some pre-existing conditions like asthma and chronic bronchitis. It results in excessive mucus secretions. It's basically an abnormal contraction of bronchial smooth muscles resulting in acute airway obstruction. Real problem to consider. Imagine having it in your office and being unable to have any kind of air movement, completely unable to ventilate the patient, even if you have a tube in the patient. High peak inspiratory pressure if you try to tube and you have the ways to measure it, decreasing oxygen saturation. And you're sitting there and wondering, wait a minute, I got a tube in, there was no laryngospasm. I am able to bag, but it feels really difficult to bag. A patient's continuing to drop their oxygen saturation. What am I going to do? You know, you really don't need to go for slashing the trach or anything like that at that point. It's not because you have an obstruction above the level of the glottis that the patient cannot breathe. It's because they have a bronchospasm, and it needs to be medically managed at that point. You may need to deepen the anesthetic, especially in the intubated patient. Consider giving some beta-2 agonists such as albuterol, racemic epi, or isoproterenol. If you can't keep moving air, at that point is when you are required to give the IM epi, the 0.1 to 0.3 milligram dose. I don't keep an EpiPen in my office. There are many offices that don't mind spending the $600 for an EpiPen that typically expires in about 1 year. But if you have that, that's a nice way to treat both bronchospasms as well as anaphylaxis reaction and airway edema from anaphylaxis. So your best bet in managing bronchospasm is, of course, prevention. If the asthmatic patient has concomitant bronchitis, upper respiratory tract infection, etc., you're probably better off canceling that surgery rather than dealing with a bronchospasm in your office. Consider steroids preoperatively or for decreased mucus production. Consider giving an anticholinergic like glycopyrrolate, Atrovent, or atropine. All of those things can help. There is something to be said about smoking cessation because smokers are at a higher risk for bronchospasm because of their higher airway reactivity. There's no point in trying to stop smoking 12 to 24 hours prior to their procedure. There's carbon monoxide and nicotine levels essentially return to normal at that point. Unless it's 6 to 8 weeks prior to the procedure, there's no significant decrease in postoperative respiratory morbidity. What we don't have data on is vaping. We have a larger number of patients that do these electronic cigarettes. I had a guy who blasted his electronic cigarette while it was sitting in his mouth the other day. That thing went into his anterior maxilla all the way to the nasal floor. Had to pull it out. And of course he did that because he had taken it out to lace it with something special for a special weekend. But now of course he's suing the company for the fact that it burst up in his mouth. And so there's something to be said about that. We don't know about vaping and its disadvantages and what the discontinuation time frame is. Now, one of the last things I'm going to talk about here is local anesthesia systemic toxicity, or LAST. This has come to everyone's forefront and attention because of the larger number of anesthesiologists that perform local anesthesia and regional blocks. But this is in particular relevant to both pediatric anesthesia in our offices as well as those of us that practice facial aesthetic surgery that inject a lot of local anesthesia over the period of time to patients' faces to do all the procedures that we do. LAST, or local anesthesia systemic toxicity, is a condition that is caused by overdosing or a hyperabsorption or an intravenous injection of local anesthesia. Typically, these patients present with cardiovascular as well as CNS symptoms and have tinnitus and disorientation and ultimately seizures associated with the condition. The CVS symptoms actually are hypotension, cardiac arrest from dysarrhythmias that are caused. Of course, it's dose dependent because patients start with seizures or delirium first and then go on to a cardiac arrest. And it could also have direct neural toxicity associated with injection near the nerve, or local tissue toxicity associated with injection into the tissues, but also it could be a representation of the patient's allergic reaction or having methemoglobinemia. Methemoglobinemia is much more common in the anesthesia setting where patients get a lot of benzocaine spray in their mouth as a part of their awake nasotracheal intubations, and those patients can go into having methemoglobinemia sooner than other patients. It puts them at a risk. There is a American Society of Regional Anesthesiology has a checklist for treating and guidelines available for treating LAST, and those basically involve asking for help and initially getting focused on the patient, airway management, maintaining 100% of the oxygen, suppress the seizures by giving some benzos. Apparently say because of propofol and its potential for cardiovascular instability, propofol is probably not a good idea. And these patients often because of their severe dysrhythmias require cardiopulmonary bypass. So it's not possible that a larger hospital in rural Pennsylvania may not be able to help you with these patients, and they need to probably be transported to the nearest facility with cardiopulmonary bypass capabilities. Management of the cardiac arrhythmia is the difference between life and death in these patients, but you may have to start off with basic things in the office, reduce individual epi dose, because remember, a lot of times you've given them a lot of epi along with the local anesthesia injection as well. The way to manage this is by lipid rescue therapy. Lipid rescue therapy is still not understood properly. we think it's because local anesthetic agents are lipophilic drugs. There is some free unbound local anesthesia in circulation that might be taken up by the lipid part of the plasma and thereby sequestered from general circulation and thus limits its effects. And so that's where lipid rescue therapy comes to be. A couple of notes on malignant hyperthermia. Malignant hyperthermia is always on our radar because of the amount of dantrolene that we have to buy and keep. Now we have Ryanodex, which is a much smaller one dose vial that we just need to keep, as opposed to 6 to 12 bottles of dantrolene that were required. Malignant hyperthermia is an inherited myopathy, basically triggering a hypermetabolic state after exposure to an appropriate triggering agent. Usually what happens is the intracellular calcium goes through the roof. It happens in 1 to 15,000 pediatric patients and 1 to 50,000 adult patients. I have to be on alert, especially in the northern Kentucky area where I get a lot of patients from. There are a lot of families with familial malignant hyperthermia history. The triggers typically are anesthetic-related issues. So the safe agents are local anesthesia, propofol, ketamine, and the non-depolarizing muscle relaxants. The anesthesia-related triggers are succinylcholine and the halogenated inhalational agents. You usually catch it because you notice there's an unexplained increase in end-tidal CO2 and a decrease in oxygen saturation. Muscle rigidity and tachycardia ensues, usually because you're standing at the head and masking the patient. You notice that the masseter muscle and the temporalis muscle has a little bit more rigidity associated with it as opposed to any other muscles. So there are people who cancel cases in the presence of masseteric muscle rigidity just because it's one of the early signs of malignant hyperthermia. I think that's reasonable. If it does seem to occur in your practice, stop all the triggering agents, change out the circuit and get a new circuit in, and hyperventilate with 100% oxygen. Call for 911 right away. Mix up your dantrolene. Dantrolene goes bad in about 8 to 12 months. Every year we have a dantrolene party. And what that does is we teach our nurses and our assistants how to mix dantrolene in a timely fashion in the right way, and that usually helps. But now with Ryanodex, although it's a little bit more expensive, it doesn't necessarily expire that quickly, and the storage has become really easy, and that's something that we keep now. Cool down the patient, lots of ice, treat the acidosis. By that time you hopefully have had your 911 come up, because you're not definitely going to get ABG in your office. You're not going to get arterial blood gases and do all the stuff. The diagnosis comes from, if in doubt, you can send them to a testing center in a large hospital. They do a muscle contracture test or biopsy, exaggerated response to electrical stimulation when exposed to the halothane or caffeine. It's not truly diagnostic. It's somewhat of a yeah, maybe this person is susceptible, but it's like one of those things with allergies. If you blame somebody that has a little, sensitivity to red color in birthday cake, then they are always allergic to birthday cake for the rest of their life in their electronic health record. Similarly, with malignant hyperthermia, if you have the suspicion, they probably will go through the malignant hyperthermia chart all the time. Dantrolene, again, dantrolene is a drug that we keep. 20 milligrams of dantrolene, 3 grams of mannitol, and 60 ml of water needs to be mixed up. Side effects is muscle weakness and hyperkalemia, GI upset, thrombophlebitis at the site of giving it. What it does is the mechanism of action. It impairs calcium-dependent muscle contraction in smooth muscles and within all of the smooth muscles. The problem is that once you've got a patient that has all of this and you've got the dantrolene cooking, this is an immediate trip back to the trip to the hospital emergency room. There's no ifs and buts about that. There's no compromise there. Say for argument's sake, everything went well and you did your pediatric anesthesia well. There is something to be said about recovery and discharge. And I think, I want to kind of beat the point about the 2 adult escorts being mandated. I really believe that this should become somewhat of a standard, if you would, only because of the issues we've had in the past. Sometimes we are in a hurry to send our patients home a little earlier, and post-anesthetic, post-recovery, post-discharge laryngospasms is not uncommon in the pediatric population. Recovery in the lateral position, basically to help avoid irritation to the cords, is key. But then, you have to personally look at the patient before you let them go out your door. Assess the level of consciousness, assess their vital signs, look to see if they are well-controlled pain, and make sure they're not ready to throw up and don't feel nauseated before you send them home. Again, the 2 adults in the same car is most important for them to go home. Complications can occur at home as well. Narcosis is a real problem. Children, especially slightly heavier children, if you use propofol in them, propofol tends to redistribute in the fat quite a bit and can cause some prolonged narcosis. Aspiration during that time could be a real problem. Inadequate pain control. I don't write for narcotics for any children at all. In fact, my narcotic prescriptions have come down a lot. Even for my third molar patients, they barely get 10 to 12 narcotic prescriptions. I give them all Marcaine shots, I give them Toradol, I give them ibuprofens. I check on them, I make sure 3 days later they're okay. Typically, you just have to draw the line and say, I'm not going to give you a lot of narcotics so you feel all grogged up at home. Sometimes an 18-year-old is still a child, and their metabolism of opioids may still be a problem. Postoperative nausea and vomiting is of particular interest to me, a topic because we're doing some research on it. They found some genetic mediators in that, and that's important to understand that not everyone behaves the same way with postoperative nausea and vomiting. Thermoregulation events. Thermoregulation events is an important thing to consider. Glycopyrrolate, if you give glycopyrrolate, causes an intrinsic increase in temperature in all patients. In the summer months, there have been deaths reported in patients who have been discharged from an oral maxillofacial surgery practice that received glycopyrrolate, that went on in an unair-conditioned car, and the car broke down midway, and the mother was changing the car spark plug or something like that. Took about an hour. The child was in the back seat of the car. Core temperature rose to about 40 degrees. The patient ended up dying post-anesthesia from an oral maxillofacial surgeon's office, and the culprit was glycopyrrolate. Keep small things like that in mind, because they are zebras and they'll show up. They will show up in your practice. So in conclusion, I want to share with you that there's a safe and effective way to do pediatric anesthesia in your practices, because if we don't do it, nobody else will, and nobody else does it well as a prepared team of anesthesia providers that we prepare in our offices. Keep your 100% oxygen, that's your friend. Accept a complication rate. There's about 1 to 6% complication rate, and that could simply be a laryngospasm. 1 in 835,000 mortality rate. Typically they say somebody else has a mortality and they can have 2, so I don't have mine, and that's true. You want to try to minimize that in your practice as much as possible. But one must understand that the majority of adverse events are related to airway or respiratory events, and can be managed with simple maneuvers. Pre-procedural health evaluation and case selection is key. Appropriate and continuous monitoring is key. Adequate preparation of equipment, medication, and monitors is important to deliver safe anesthesia. Appropriate recovery prior to discharge is important, and simulator training enhances your skill. It's very low risk, but the high stakes of training. That's the way to keep your skills up. So get your simulation team together, get your staff together, order some pizza, order some beer on a Friday afternoon, cancel clinic, and just do simulation scenarios. Makes a big difference to the way you'll be prepared for your practice. Thank you very much for those who have stayed on and endured the postprandial torture. So for those Joe, what I've done is I have added a section on geriatric anesthesia at the end of the section. I'm not going to talk about that, but there's about 50 slides on there on geriatric anesthesia as an add-on bonus for this crowd who decided to bear the weather and come and sit through this teleconference. I think I have a sacral ulcer from sitting around and lecturing to you for the last 7 hours or so, and I'll send you the bill for that, Joe. Thank you very much.
Deepak, thanks so much for the wonderful talk today and being so helpful with the whole situation that we've had to endure over the last few days. Thanks everybody for coming. Just one last thank you. He's not in the room, but Jules Vergara, one of our IT guys, there you go, from our practice. We couldn't have done it without you because, frankly, their AV department was worthless. So he set this all up, and thanks again.
Thank you very much.